lipidemia and cardiac risk. This is kind of a topic that should be early in the morning when everybody's wide awake. I'm not sure how we're going to do it now, but I'm going to speed through this thing and going to leave with a few salient points. I'm a cardiologist. I treat lipids every day, and I use some three basic principles to guide me. So we're not going to worry about LDL subclasses, small dense particles, large particles, LP little a, and things like that. That gets very complicated and academic. But from a practical standpoint, I'm going to try and guide you through how we make our own decisions. And it is not very difficult. There has been a lot of research on lipids, a lot, and still ongoing. But in case NEPA takes light and I forget to say anything, most important thing is LDL is the main thing you look at for risk and for treatment. Every other trial of any drug to change HDL, do anything else, has not shown any improvement in mortality. Only things that have shown improvement in mortality is lowering the LDL. So that's what you should target. So you don't have to start memorizing ratios, HDL, LDL ratio, cholesterol, HDL ratio, and all those things. They are helpful, but from a practical standpoint, your LDL is what you want to know. Okay. All right. So as far as statistics goes, cardiovascular disease, the most preventable form of cardiovascular disease is coronary artery disease. Now, in Nigeria, that might not exactly be true. I think here, the most preventable form is treating your blood pressure, because we have a lot of heart failure from hypertension. But as the statistics show, by 2020, coronary artery disease is going to become the leading cause of death and disability worldwide. That is, with especially what we ate for coffee break and what I saw you people eating for lunch. I'm happy to say I did not join you in that endeavor. I saw people eating their ofada stew with relish and putting meat by the side to kind of erase the guilt. But so this is going to catch up with us very soon. We're already seeing it, and it's coming fast. Now, in spite of all this prevalence, all the studies show that this process of atherosclerosis can be slowed down and the consequences reduced by preventive measures. So there's a lot we can do as primary care doctors to reduce the incidence and prevent this from happening. And those of you who go to church, go to the mosque, you can tell your people, because they have health talks there, you can advise them. There are things we can do to reduce the incidence of heart disease before it becomes a problem. Because we don't have health insurance, nobody can pay $2,000, I mean 2 million, was it naira for a stent? So please tell your people, stop eating their father's stew, eat fish, boiled fish, and so on and so forth. Okay. So death rates from heart disease and stroke have declined steadily in the US. Incidence is going up in the developing world, otherwise known as the third world, Nigeria, which is the capital. All right. So what are the categories of risk factors? Well, we're going to concentrate here, but generally we all know these things. Non-modifiable risk factors. Age. The older you get, the higher your risk. There's nothing you can do about that. Sex. Men get more heart disease than women. That's just the rule of life. I think it's just harder being a man. Family history. Anybody in your family, especially first relatives, have heart disease, you're at higher risk. And of course, genetic. Now, the modifiable risk factors: smoking, ofada stew diet, alcohol intake, physical activity, lipidemia, hypertension, obesity, diabetes, and metabolic syndrome. Now, this is where we need to concentrate our efforts, because these are things that we can directly affect and reduce the incidence. Now, there are these emerging risk factors: C-reactive protein, which I mentioned earlier, fibrinogen, coronary artery calcification, homocysteine, small dense LDL. We won't go into that today. Now, what's the difference between primary and secondary prevention? I'm sure most of us know this, but I will just refresh your memory. Bottom line is, primary prevention is to prevent the disease from happening in the first place. So that's what we do in our well care clinics and things like that. look at the risk factors and try and prevent those risk factors from becoming disease. Secondary prevention is if somebody has already had an event or has been diagnosed with coronary artery disease, like you've had a heart attack, you've had a stroke, then you're now into secondary prevention, which is to prevent a recurrence or progression of that disease. Now, the goals are different for primary and secondary. The goals of treatment for cholesterol are different, but the treatment is the same. Now, the Framingham study, which is the grandfather of all studies for risk factors. I won't go through the study, but we'll go through the risk factors that have been identified as risk factors for coronary artery disease. Now, you should all know these risk factors. Age, the older you get. Gender, male. Family history of premature heart disease. Now, remember that word, premature. If somebody's father died at 90 of a heart attack, it does not put his children at risk. In fact, that's actually good genes. So, male relative below 55 years or female below 65. All right, so people who die or have heart trouble in their 70s, 80s, they don't put you at risk. Now, one thing we all patients tell you, oh yes, my father has hypertension, my mother has diabetes. That's not a risk factor for that individual person. It might be a risk factor for diabetes or hypertension, but that is not what we call family history. The family history is of premature coronary artery disease. Now, the cholesterol, elevated total or LDL cholesterol level. Now, that's where we're going to concentrate. Reduced HDL cholesterol level. Now, these are all risk factors that are put into the Framingham risk factor scale, and there's a computer calculation for this. I'll show you how it's done, but it's complicated, and I like to simplify things. I'll show you my own simple method. Smoking, like we agreed, smoking is not a problem in Lagos. Might be in Uyo and all those places, but in Lagos we don't smoke, I'm pretty sure. But I'm surprised to hear that smoking is a problem. I was actually surprised. I thought it was not a problem at all. Hypertension, we all know that is our badge of honor in Nigeria, partly because of our diet. Diabetes is also a big risk factor, and it is actually now called the coronary artery disease equivalent. So if you have diabetes, it's like you've already had heart trouble. So it's a big risk factor. Obesity and sedentary lifestyle. Okay, now this is how the Framingham computes the risk. Now you don't need to memorize this. Most people use a computer to go through all of this. But you can see age. I think it might be too small for you to see. But generally, they add up all the points. So you go from age to age. Age under 20, you see, is 0 points. Age above 70 is 12. High cholesterol is 11. And blood pressure and all these things, they add all of them, and then they give you your 10-year risk. Low risk is, high risk is above 20%. All right? And then we'll go through those risk things a little later, but that's one way of calculating the risk. It's a nice way of doing it, but you have to get a lot of factors and add them up and then come up with the risk. Most of us don't have time to do that, but it can be done. There's a little computer program you can buy and do these things. Now, most of the benefit in reducing heart disease comes from management of 3 major modifiable risk factors: high cholesterol, hypertension, and smoking. So smoking, we've talked about, we're not going to discuss. In my opinion, smoking is equivalent of riding an Okada with the Okada driver blindfolded against one way on Ikorodu Road. It's just a senseless thing to do. It just makes no sense. I used to be a smoker and smoke about a pack a day. And I didn't stop till I saw one of my classmates die from lung cancer. And then that's when it occurred to me that this thing is real and it's not just in the textbooks. Hypertension, we all know. Everybody treats hypertension every day. So we'll talk about lipids. Okay, metabolic syndrome. What is this metabolic syndrome? Even for me who does this every day, there are about 100 definitions of metabolic syndrome if you look. So, but basically, they all come down to the same thing. This is the ATP definition. Abdominal obesity, which means your waist circumference above 40. Now, it's not all this one that will start doing the waist down here. No. It is up here where your belly is fat, right across the belly button. And I guarantee you, if we measure ourselves here, you'll be surprised. You're not the 36 you are claiming. Most of us have been hanging on that 36 for a lot of years. You'll find out that we are not 36, might be closer to 40. All right. Now, serum triglycerides above 150. HDL below 40 in men and below 50 in women. This is very important because a lot of people will say women with an HDL of 45 and say it's good. No, in women, it should be above 50. In men, above 40. Hypertension, whether or not you're on treatment. Once you're hypertensive, you've got metabolic syndrome. Fasting plasma glucose of over 100 and or on treatment. So now you don't have to have all. If you have any three of these criteria, you fall into the metabolic syndrome category, and that immediately puts you at high risk. So you see, diabetes is not there, but impaired glucose tolerance is there. Okay, this just shows you, which we all know, but to refresh your memories, the relationship between high cholesterol and coronary artery disease. The higher your cholesterol, the higher the risk of death. Framingham study, Mr. Fit study, the higher cholesterol, higher the risk of coronary artery disease. It's just simple, straightforward. Shows you some more evidence. Now, look at all of these studies. The men are always in the high category. This is in Japan. Any cholesterol above 218. You see, women have a high incidence, 200, but the men are up there, 400 and something. So, men just have a hard time with this thing. Okay, so what are these coronary artery disease risk equivalents? All right. Now, diabetes, we've discussed that. Diabetes is a risk equivalent. So, once you have diabetes, it's like you've already had coronary artery disease. You should be treated as such. Atherosclerotic disease, which are peripheral arterial disease, aortic aneurysm, and carotid artery disease. Now, I noticed my own medical officers, I never ever see them put a stethoscope on the neck or in the abdomen. When they listen to the abdomen, they're listening for bowel sounds. They're not listening for abdominal bruit. Now, these are things you should do on your physical exam on patients. If they have bruit in their groin, in their abdomen, in the neck, they have vascular disease. They're at much higher risk than a regular person. All right, so you should look for these telltale signs. They're easy to look for. An aortic aneurysm might not be easy to find, but if you put your stethoscope there, tell the person not to breathe, and you hear what sounds like a murmur. That's a bruit. Shouldn't be there. That usually means there's something there, and you probably do an ultrasound, and you find an aneurysm or atherosclerosis. If they have bruit in their groin, or they don't have distal pulses, then they probably have vascular disease, and they're at high risk. I should always listen to the neck. And any of these things puts you at a 10-year risk of above 20%, which is quite high. Okay, so we're getting to the end and beginning of this talk. Where are we going with all of this? We want to treat our cholesterol. Like I said, what you use for treatment of cholesterol is your LDL. All right? If you can't remember HDL, triglycerides, and all these things, the most important thing is LDL. LDL treatment is what has been shown to reduce mortality. All the rest, the evidence is not strong. So, anybody with coronary artery disease or coronary artery disease risk equivalent, you want the LDL below 100, which means your diabetic patients, including the banker, and we were talking about that earlier on today, should have a cholesterol LDL of below 100. Any diabetic, I don't care if everything else is fine, the LDL should be under 100, which means most diabetics should be on a statin drug. Now, we will talk briefly, or you might want to ask me about the relationship between statin drugs and diabetes. There's a risk of increasing there's a risk of more diabetes, of causing diabetes in a patient who's borderline by putting them on a statin drug. So that's an important topic to discuss. I think that's for tomorrow, but we can go over it if you want me to. Then, anybody with multiple, that is more than 2 risk factors, any of those factors we've listed. So anybody who's above 70, anybody who has high cholesterol, they've already gotten 2 risk factors. Hypertension makes it 3. Hyperlipidemia makes it 4. So anybody with these risk factors, above 2 risk factors, you want your goal of LDL to be low 130. And anybody with no risk factors, at very low risk, you want 160. Now, the textbook says 160. I can tell you that I don't feel comfortable. I'm sure most of us don't feel comfortable with an LDL of 160. But the textbooks say you shouldn't start on drugs, but you should still encourage them to get the LDL down by non-drug methods. Now, this just shows a meta-analysis of most of the studies showing reduction in cholesterol reduces mortality. So this is the cholesterol treated, and this is untreated, and you can see as time goes by, the divergence of the curves gets more, and it doesn't look like much, but it's significant. And for each percent decrease in LDL, you reduce your heart disease by 1%, and each percent increase in HDL reduces your heart risk disease by 3%. So this shows you HDL is a protective cholesterol fraction. Now that's another story about what drugs you use to raise HDL and if those have been proven to reduce mortality. They haven't been. There's still a lot of research going on there. And this shows you what I showed you before, the goals we're going to try and attain. This is the risk. Low risk, 160 LDL. Very high risk, that is somebody who's had an acute coronary syndrome like a heart attack, unstable angina, has had a stent. You're aiming for a cholesterol LDL of less than 70. All right? But the key numbers to remember are 160, 130, 100. Anybody with more than one risk factor, you want two or more risk factors. Two or more risk factors, you want 130. Below 130. Anybody at very low risk, below 160. Anybody with a diabetic risk equivalent, anything like that, you want below 100. Okay, what drugs do we have available? These are the different classes of drugs. We have the statins. I can never pronounce this, ezetimibe. Bile acid sequestrants, which is like cholestyramine. I'm sure some of you who've been in practice a long time remember using those drugs. Nicotinic acid, which is not easy to get in Nigeria. In fact, I don't think I can get it. It's difficult to get here, but they're useful. And fibrates. Now, I'll just quickly go through what they do. Now, the mainstay of lipid management is statin drugs. All the other drugs are supplementary. The mainstay is a statin drug. Statin drug will reduce your triglycerides significantly by up to 30-40%. Reduce your LDL by up to 50%. Can raise your HDL by up to 12. I mean, this is total cholesterol, sorry. Reduce triglycerides here by up to 30%. And most patients can tolerate this. Now, bile acid sequestrants, very difficult to take. Very, very difficult. Nicotinic acid, very difficult to take. I've been on nicotinic acid myself. It is a very difficult drug to take. You've got to take your aspirin 30 minutes before you take the drug. If you drink wine or anything like that, after you take that, you feel like your body's on fire. Yes, so it's not an easy drug to take, but some people need the drug. So it's important to know about it. But 90% of our patients will be treated with statin drugs. 90% or more. Okay, this just tells you the different drugs and their strengths and some things about them. Now, the strongest drug we have available is Fluvastatin, which is Crestor. Reduces your cholesterol by up to 63%. Now, the weakest of all the ones we use is Fluvastatin. That is the weakest drug. And remember something about Fluvastatin. The only dose of this drug that is useful is the 80 milligrams extended release. The 40 milligrams regular dose, 80 milligrams regular dose is not a very useful drug. The only time I use this drug is if the patient develops muscle cramps from all the other drugs, then the extended release, people who have severe muscle cramps with all the other drugs. And remember something, because you have muscle cramps with Crestor does not mean you will have it with Lipitor. So if you have a patient who needs to be on a statin drug, try low doses of the other drugs before you give up on a statin drug. Because this drug saves lives. And do your best to put the patient on that drug. If they can't tolerate it, then you start looking at alternatives. But the statin drugs are key. Okay, now I'm going to go over two trials that are very important. The Jupiter trial, which used, justification for the use of statins in prevention and intervention trial evaluating rosuvastatin. What they did was put people who had normal cholesterol, LDL below 130, who were at normal or low risk, but had a high sensitivity CRP of above 2. So this is normal cholesterol, high sensitivity CRP above 2. They put them into a study and put half of them on rosuvastatin and half on placebo. Now this was about 17,000 people, a very large study, all around the developed world, including Africa here, South Africa, close to us. Now, remember, all they had was no other risks, no diabetes, nothing like that. LDL below 130, low risk, but high sensitivity CRP above 2. And they looked for these endpoints: MI, stroke, unstable angina, CVD death, bypass surgery, or angioplasty. And there is a big difference in event rates, and 44% decrease in event rates. And remember, these are people who were not at high risk. These are people who are supposed to be at low risk, like that banker that we talked about. That's why I was asking what the CRP was. So one of the things you can do when you're treating your well patients or your executives who come for their checkup is check the high sensitivity CRP. All right. Now, I will come to a slide which, after this, which will just simplify all of this for all of us. Now, the other study that's very important, the CARD study, which gave 10 milligrams of atorvastatin to patients with type 2 diabetes who did not have high cholesterol. You know, to put anybody with high cholesterol in a study where you don't treat them is almost unethical right now. So, but these were patients without high cholesterol, supposedly fairly low risk, other than the diabetes. And once again, there was a marked difference in endpoints of major cardiovascular events between placebo and atorvastatin. So this in summary said it is a safe drug. It is effective in reducing the risk of cardiovascular events, including stroke, with patients with type 2 diabetes. So, if you don't remember anything about lipids, just remember this last slide. In fact, I can stop here. Yep, it's 5:20. This is the most important slide. For those of us in primary care, a simple evidence-based approach to statin therapy for primary prevention. In men and women above the age of 50, if they're diabetic, they need to be on a statin drug, unless there is a contraindication. Every diabetic should be on a statin drug. Simple as that. If the LDL is above 160, they need to go on a statin drug. If high sensitivity CRP is above 2, they go on a statin drug. When you look at all the trials, everything, this is the basic summary. Now, of course, there's some outliers and different things for different people, but basically, this is what you need to remember. Any diabetic, statin drug. Anybody LDL above 160, statin drug. High sensitivity CRP, statin drug. And I think I will take any questions from now. Oh, and let me talk about the diabetes, just in case some of you are not here tomorrow. Now, there is an increased risk, significant risk of precipitating diabetes in patients who start on statin drugs. I think the risk goes up to about 20-something%. It's a high number. It's not insignificant. So it's not something you should just ignore. There is a chance that you put somebody on a statin drug and they develop diabetes down the line. Now, it is likely that I was a high risk of diabetic, of possible diabetics in the past. But the fact is that the statins did increase the incidence of diabetes amongst these people. But the bottom line is the reduction in mortality and cardiovascular events far outweighs the risk of them developing diabetes. So even if somebody develops a high sugar of 126, 127 on a statin drug, they're better off on the statin drug than not being on it. So a lot of patients have stopped their statin drugs because they've read about all of this. The newspapers have carried it around. But always try and let them know the facts. they are still a lot better off taking the statin drug. The diabetes is a risk. It's not nice to have diabetes, but it is much nicer not to have a stroke or a heart attack and things like that. Now, being on a statin drug is almost like a Catholic marriage. There's no divorce.
Seriously.
It's like your high blood pressure medications. When you stop it, your cholesterol goes back up. Unless, of course, the patient was 100 kilos,
That's what I'm thinking.
ate everything he liked, and you started him on the drug, but then after some time he decided to lose weight, went down to 70, and cholesterol came down, and you stop his cholesterol drugs. You have to stop for at least 6 weeks to remeasure and see if cholesterol is still down. But the high-risk people, the diabetics, it's forever. The CHD equivalent is forever because they already have disease. Secondary prevention is forever.
If the diabetes is induced by the statin, and wouldn't the diabetes reverse if
No,
you
you see-
stopped it in those people who's
Yes,
causing
good
heart
question.
factors?
Good question. Yes, yes. If somebody's diabetes was induced by Crestor, for instance, you remember that you didn't put him on Crestor for no particular reason.
I agree.
You put him on Crestor either because LDL was high
Mhm.
or high sensitivity CRP was high.
Yeah.
So they were already at risk before they developed the diabetes. When now that they develop their diabetes, it means their risk is generally high in the first place. They probably had something going on that we couldn't detect. So taking them off the statin would probably not be a good idea.
If there were contributory factors to the how do I put it? The risk situation.
Like somebody who
If you just giving us examples
yes,
of an obese person,
hmm
a smoker, and all those. If those things are removed, which naturally would have helped to reduce
yes.
the risk.
Majority of metabolic syndrome is because you're fat, pretty much. So if you suddenly see the truth, you see the light, you found your way, and you now decide to start eating right, exercise regularly, go on a low cholesterol diet, do all the other things, and your cholesterol comes down, your risk factors change, then you don't need to be on a statin drug. That's for sure. That is for sure. Now, as far as, which is also important, then non-medical ways of, non-medicinal ways, non-drug ways of bringing down your cholesterol, which are important, we talk about. Now, number one is diet. There's a lot of talk about diet, but we all know the diet is quite an important factor. You need to go on a low cholesterol diet, low saturated fat diet. You can try the Mediterranean diet, anything you do, but go on a diet. Stop eating more meat and things like that. Your cholesterol might come down. Most of us eat meat every day, lunch and supper. Some people don't even want to see fish. So if you've been like that and you turn around, of course things will change. So diet is number one. Number two is exercise. Exercise reduces your LDL and it improves your HDL. So somebody who wasn't exercising before now starts to walk a mile every day before he goes to work and things like that. He's going to turn his metabolic picture around. He will. And I've seen quite a few people like that. Something usually triggers them into action. Something like somebody died and then they just suddenly decide, okay, it's time for me to straighten up. That's what made me stop smoking. So I know something triggers people and at the time I was smoking too, I was weighing about 100 kilos. So, that's easy. That's easy because my father said I shouldn't smoke. So I had to prove to him that he can't tell me what to do. Yes, you see. So exercise, diet, those are two important things. Now, also in this diet, eating fruits, vegetables, and things like that, reducing your carbohydrate intake, all improve your HDL. All right? The more rice, dodo, and things you eat, it tends to bring down your HDL. If you eat more vegetables, fruits, things like that, nuts, your HDL goes up a little bit. And that's also very helpful. As your HDL goes up, your LDL comes down. Your triglycerides come down. So those things are good. Now, what are the other things we can talk about? I'm surprised nobody has asked me these questions yet. Number one, I keep getting asked about every day is garlic. Some people just take a lot of garlic because they've read on the internet garlic reduces your cholesterol. Well, garlic has been studied extensively. There's no evidence that it reduces your cholesterol. All right. So maybe it does, but there's no evidence to show that it does. Now, there's another thing you should look for. Red rice yeast. All right. Now, surprisingly, this is a Chinese product of rice fermentation. And it actually does lower your HDL, your LDL. Now, it does contain some substances that are similar to Fluvastatin, HMG-CoA reductase inhibitors. So, it does have those kind of substances in it, but those things actually do help bring down your cholesterol. Now, fish oil, been talked about a lot. Fish oil doesn't have any effect on your LDL, but it will bring your triglycerides down. All right, so these are the things you can do non-medically to improve your risk factors. And of course, number one factor that you can deal with is smoking. Anybody who smokes is just on a suicide mission. Not everybody is going to be lucky. 80% of smokers are going to get hit by something that could have been avoided. Huh? Very good question. Now, I will tell you this. I'm not sure I've told my partner this yet. Okay. We are authorities on that one for a variety of reasons. But alcohol in moderation has been shown to improve your HDL. All right? In moderation. Which means 2 glasses of wine a day with meals for men and 1 glass for women. And 2 glasses means wine glasses. There's 4 glasses of wine in a bottle. So if you take 2 glasses and you finish the bottle, you've taken more than the 2 glasses. All right, so it's 2 wine glasses of alcohol that has been shown. Above that, the risk of alcohol sets in. And it's not just the heart, it's liver problems, heart failure, things like that, alcohol dependency, and all those type of things. So alcohol in moderation is okay. Now, that does not mean somebody who does not drink alcohol should now go and start drinking red wine. It's probably not a good idea if that's the reason you want to drink red wine. But if you drinking red wine is where most of the studies have been done, but it is believed that all alcohol have the same effect. Only thing is 2 bottles of beer will probably give you a 3-4 month pregnancy that you have to be carrying around. What was the other question? Red wine, alcohol.
And all that in it with the pectin literature. But generally, I think it has to do with the fact that many of those things that contain, the red pigment, as in what is in red wine too, would constitute some form of antioxidant. But it's not a direct effect because, again, those antioxidants, there's also a study that says that it would work, especially vitamin E and the others, will work against your statins. So you have to marry the risk.
Okay, and that reminds me, something else I forgot in the diet. Plant stanols, all right? They're actually also supposed to be good in reducing your LDL and upping your HDL. Now, the common one in the US is called Benicol. In Europe, and I think we get it in Nigeria now, is Promise. Promise Active. I think that's the name. Promise Active. It's a type of plant margarine. Now, it's supposed to help improve your HDL and LDL. It works in the stomach by preventing absorption of these things. Studies have shown that they're quite helpful, but also notes that they also have a lot of calories. But those are things you can do. So instead of margarine or butter, you can use those things. You can actually use them in cooking as well as olive oil and things like that. And they're better for you. So there's a lot we can do without drugs. Drugs are after the diet has failed, but still, some patients now, once you put them on the drug, they say, Doc, that means I can cheat now. So I can go on, I can start eating meat. And I can tell you from personal experience, Kofo thinks I check my cholesterol too often, but I check it because I have access to it. So maybe every 2 weeks, sometimes every week. And I can tell you, my LDL is usually in the 60s. But when I start eating meat and of fat as stew, it goes up to the 80s and 90s. And it's consistent. It is very consistent. I eat meat 2-3 days. I check my cholesterol. It has gone up. So I don't like bushmeat. So to me, bushmeat is just a big rat. I don't like bushmeat. I don't like it. But I've tested it. Cholesterol goes up. Yes.
Sorry, I was just wondering how common is rhabdomyolysis as a side effect of statins?
Very, very uncommon. I've been doing this for I don't know how many years, but a long time. 20 something, 30 years. I've seen one case. One case. And it was a debate as to whether something else caused the rhabdomyolysis or the statin did. It's not common. But when it happens, it's a big problem. And if you don't recognize it, you can cripple that person for life. So it's very important that you pick it up. So do not discount the patients when they tell you they have muscle aches. Check it out. It is not common, but when it happens, it's a serious complication. Cause renal failure, cause muscle necrosis and bad things.
Chemical entity may be uncommon, true, but one can't ignore the frequency with which one sees patients on a statin complaining of muscle pain that resolves after you have stopped the statin. And it's perhaps the most common cause of switching statins in my practice.
I'm one of those who believe the incidence of myalgias is much higher than it is written down in the literature. Because I take statins. And I know when I'm feeling bad, I just stop my statins for 2-3 days, I feel good. Then I take them again. But I have to make the decision. Do I want a heart attack or do I want muscle aches? So it's easy for me to decide. So yes, they do cause muscle aches. So it's important not to discount these patients. Now something that helps with the muscle aches is Coenzyme Q. It does help with the muscle aches. To me, that's the only advantage of taking Coenzyme Q. Nothing else that it helps, but people think it does help. But Coenzyme Q does help with the muscle aches. Taking the statins at night with food helps a little bit. But if they have muscle aches, try a reduced dose and see what happens. Because these statins do save lives. But it is true. If on weekends I cut my dose down so I can play golf and run around and not have any muscle aches. Because the muscle aches are there. They are there. They're more frequent than is written in the literature. But if you empathize with the patient, he understands, you know he has muscle aches, and then you say, okay, let's try a reduced dose. You understand, we'll put you on this drug to save your life. We don't want you to go and have a heart attack and things. They understand, and then they can decide for themselves what degree of muscle ache. But if CPK is going up and things like that, then it's probably not a good idea for that patient.
I want to know the possibility of a female patient in she wants to get pregnant, but she's hypertensive, diabetic, and she's also on atorvastatin. What is the chance of the person being on the...
Oh, that one is easy. If they're pregnant, they stop the drug. First of all, it is unusual to have somebody with high cholesterol getting pregnant and all those sort of things. Because the age group we focus on is 50 and above. All right? But if for some reason somebody is on a cholesterol drug, generally, unless they have one of these severe familial disorders, generally stopping the drug for 9 months is not going to be the difference between life and death for that patient. So a statin drug is not a common problem. It's not a problem I come across, stopping a statin drug. The ones I come across are blood pressure drugs. And you can't stop blood pressure drugs. You have to find the ones that are safe in pregnancy. But statin drugs is not a common thing. I'm not sure I remember anybody asking me to do that. But generally, it is generally safe. Actually, there are people in their 40s who get pregnant. So in those cases, I say, look, come off your drug. Have your baby first, and then we'll deal with it later. I can guarantee you it has not been studied. I don't know. But I know nobody's going to study it. I don't know. No, they will say not studied. Category C or D.
Please.
There can't be any ethical way of studying that drug.
Please, I would like you to
say something about alternative to aspirin because some patients seem unable to tolerate them.
Because some patients what?
Aspirin, alternative to aspirin.
Okay, it depends on why you are on aspirin. If you're on aspirin for primary or secondary prevention, if you have a stent, if you've had a stroke and things like that. So it depends on the reason you are on aspirin. But as far as primary prevention goes, as we all know, each time a new study comes out, we don't know what to do as far as aspirin goes. 10 years ago, everybody in this room was on aspirin. Now, we are not on aspirin unless you have 2 or more risk factors. So it depends on what you're on aspirin for. But the usual alternative is clopidogrel, which is a Plavix. That's the usual antiplatelet drug we use, depending on what you are on it for.
Okay, doctor, you said we shouldn't eat meat. That is cow's meat. What of goat meat? But I always say meat is meat. But sometimes I'm not really convinced. What's your own opinion about it with chicken too? Chicken is meat now.
Okay. I can answer part of it easily. Chicken is good without the skin. Not the chicken we ate today that was fried. That one is not good. But it was very sweet, but it's not good. Okay, now meat. Any form of red meat is not good. All right? Now, that does not mean meat is a no, you cannot eat meat. No. It just means the more meat you eat, the higher your risk. So if you eat corned beef omelette for breakfast, you eat Ghana High or something else with assorted for lunch, then you go home. You also now eat, okay, you're going to just not eat red meat, you're just going to eat cow leg and things like that. You are just upping your risk. All right? So any form of meat is bad. Now, goat meat, there's some controversy about goat meat. Depends on the part of goat meat and whether or not the skin is there. All right? If the skin is there, it's bad. It's very fatty. So if the skin is not there, it's actually leaner than cow meat. But then some people say there's a difference between the male goat and the female goat. So I haven't studied goats that far. But red meat is not good. Oh, there's a difference, so you don't know. You're laughing. The male goat smells bad. Oh, okay. Okay.
Type 2 diabetes. The accepted wisdom is that any diabetic over the age of 40 should be on a statin. It's evidence-based, I believe. And that's the practice, certainly in my practice in the UK. But how does that, is that so here? I mean, do we prescribe a statin for every type 2 diabetic patient over the age of 40?
I don't know what the standard of care is here. I don't know. I know what I do. I know what a lot of people do. But I think most people who treat diabetes put them on a statin. But then our patients here are also very different. They will decide what drugs they're going to take. You know, by the time you see them the next week or next month, they're on a completely different list of drugs than they left you with. So that part of it is very complicating. It's not straightforward at all. But I don't know what majority of people practice. But I do know the evidence is you should treat diabetics with a statin.
And hypertension. So the thing is not to, and this is the message that we in our practice have been trying to disseminate. The fact that studies have not been done here should not be taken as liberty to dismiss studies that have been done on people just like us. I can tell you the people sitting in this room have the same genetic code as the African Americans in America. They belong in the same educational strata. They belong in the same socio-economic strata as many of the people that are studied. So there is no conceivable way or reason to now not treat based on what there's evidence. The ASCOT trial, the HPS, many of those studies show that when you have diabetes, hypertension, if you treated just those things alone, as opposed to treating lipid levels that are actually in the normal range. That's where you can see the stagger between when you don't have risk factor and when you have risk factor. That's where all that data comes from. So unless people have already met the goals based on those cutoffs, if you find that they have hypertension, they have vascular disease, they have diabetes, you have to put them on statin unless there are specific reasons, such as people who have extenuating circumstances, and that is evidence-based.
Thank you very much to our eminent panel of cardiologists and psychiatrists, and thank you to all of you for taking the time to come today. It's been a wonderful learning experience. This is the first day of 4. It's a 2-part series, February and in March, Hearts and Minds, and Diabesity. The message is that it's one disease, diabetes and obesity. It's part of that cardiovascular spectrum. So if you haven't registered for that, please do so. You can order the DVDs from this and the first 3 masterclasses as well. You've all got the order forms. And thank you very much. We'll see you tomorrow.